Hi and welcome to OneMedicine. Today I'll be talking about Pityrosporum folliculitis. Pityrosporum folliculitis is also called as Malassezia folliculitis, named after the organism which causes it. So this condition is an inflammatory skin disorder that presents as a pruritic follicular papillopustular eruption distributed on the upper trunk of young middle-aged adults. So it's an inflammatory disorder basically. So there's inflammation associated and it presents as a pruritic, that is itchy, localized to the follicles, follicular papules and pustules, mainly situated on the upper trunk, seen in middle-aged young adults. It is caused by Malassezia furfur and other variants of the Malassezia species. Etiopathogenesis. This Malassezia furfur is a lipophilic, saprophytic, budding, unipolar, dimorphic, gram-positive, double-walled, oval to round yeast. So this yeast is a lipophilic, saprophytic, budding yeast. It is also a part of the normal skin flora. The identical morphological variants of Malassezia are Pityrosporum ovale and Pityrosporum orbiculare. The organism is normally present in the ostium and in the central and deep segments of the hair follicle. So hair follicles are where this particular organism is present. And the plugging of the hair follicle with the overgrowth of the yeast is said to cause the overgrowth of this yeast in the sebaceous environment. So this is the etiology of Malassezia folliculitis. These Malassezia organisms, they need free fatty acids for their survival, and these free fatty acids are mainly present in the stratum corneum and also in the hair follicles they are present. So they reside in these particular places for their survival. These yeasts will hydrolyze the triglycerides into the free fatty acids, and they will create long chain and medium chain fatty acids. So these fatty acids will activate the cell-mediated immunity and activate the complement pathway, causing inflammation. Serum antibody titer to Pityrosporum is raised in Malassezia folliculitis. So antibody titers would be raised here. So this is the etiopathogenesis. The lipophilic Malassezia yeasts will hydrolyze triglycerides present in the stratum corneum and the follicle. They will hydrolyze that to form the long chain and medium chain fatty acids from free fatty acids. They will result in cell-mediated immune response activation and also alternate complement pathway, which will finally cause inflammation, which is seen in the follicles. Clinically, we see chronic extremely pruritic papules or pustules in perifollicular erythema also is present. The most common sites that we see these lesions are on the back, the upper chest and the arms. These are the sites wherein the follicles are seen. The perifollicular erythema is present and papules and pustules are present. They are discrete 2 to 4 millimeter in diameter, erythematous monomorphic papules. That is, they're red in color and the lesions are similar. All the lesions are similar. That's why it is monomorphic. We see papules and later they form pustules in a follicular pattern. And the materials are expressed from these pustules. They are white to yellow in color if you press it. And the other sites that are involved are neck, shoulders and face. Uncommonly, they are also affected. In Wood's light, we see bright blue or white colored fluorescence in clinically uninvolved follicles in the location of the lesions. So Wood's lamp will help in diagnosis. Clinically, it's a bedside test. It's a simpler way of diagnosing P folliculitis if there's a confusion. So bright blue or white fluorescence can be seen. Along with the folliculitis, that is Pityrosporum folliculitis, there can be associated seborrheic dermatitis also. Seborrheic dermatitis also presents in a similar area, that is in the seborrheic areas of the face, neck, upper chest and back areas. So that can be confused with seborrheic dermatitis. So these are the lesions of Pityrosporum folliculitis. You can see here the upper chest, you can see follicles, skin color to erythematous, follicular papules are seen in this condition, right? So these are the papules, which then later they can form pustules as well. Histopathology, the Pityrosporum ovale is found in the follicles, mostly in the yeast form, and there you will see perifollicular mononuclear infiltrate, and around the infundibular region there is perifollicular mononuclear infiltrate. So these yeast forms can be found in the follicles. This is a photo showing the yeast forms in the follicles present here. Differential diagnosis would be acne vulgaris. Acne vulgaris typically again presents in the seborrheic areas, most commonly on the face, but otherwise it can be seen on the upper chest and upper back also. It can be bacterial folliculitis like staphylococcal folliculitis, then steroid folliculitis. Post-steroid, there can be follicles, similar lesions which arise on the particular sites. as folliculitis, eosinophilic folliculitis, rosacea, demotic folliculitis. So all of this can present similarly. Treatment would be, as it's a fungal infection, you can give topical and oral antifungals can be given. It's a yeast infection. So topical and oral antifungals can be tried. Most effective would be by giving oral antifungals. They help in rapid elimination of the yeast. Oral pulse itraconazole can be given, or weekly fluconazole can be given. So 200 mg per day of itraconazole can be given for 7 to 10 days. If it does not subside, for 1 to 3 weeks also it can be given. Oral ketoconazole and ketoconazole shampoo with 2% ketoconazole shampoo applied twice weekly can also be given. Other topical agents that can be used are, we have salicylic acid solution, cyclopyroxolamine, econazole cream, selenium sulfide 2.5% shampoos are available. They can also be used. Newer treatment option that is upcoming is a topical photodynamic therapy with methylaminolevulinic acid. That is given for recalcitrant malassezia folliculitis. You can try the photodynamic therapy. Otherwise, mostly with topical and oral antifungals, the lesions will subside.